Hi, everyone. My name is Jessica Farrell. I'm a clinical pharmacist at Albany Medical Center Division of Rheumatology in both adults and pediatric rheumatology. I am also a professor at Albany College of Pharmacy and Health Sciences, and I also serve as a member of the board for RAP. So today we are going to do a journal club. We are going to talk about an article that was published just in February of 26. It's titled Efficacy and Safety of Guselkumab in Participants with Active Psoriatic Arthritis After Inadequate Response to One Prior Tumor Necrosis Factor Inhibitor or TNF-alpha inhibitor, a week 24 results of a phase 3 randomized placebo-controlled SOLSTICE study. So we've been talking a lot about IL-23 inhibitors on the podcast, and this is a very exciting study because it is going to be a little bit more realistic to the patients that we see in clinic regularly. In general, a lot of our patients with psoriatic arthritis who are not newly diagnosed have had TNF exposure. So it's helpful to see what that data looks like in terms of, do our patients that have had prior biologic exposure, do they respond to therapy? So there are a couple things, and why are we talking about this study specifically, other than the fact that we want to know how they do specifically after TNF failure. But in the Discover 1 and Discover 2 trials, so those were the studies that looked initially at guselkumab in patients with psoriatic arthritis. And there really was only a subset of patients in Discover 1, I believe, that had prior TNF exposure. So it was only a little over like 35% of patients. And when they did a post hoc analysis on that subset, they had seen that those patients might respond differently compared to the biologic naive patients, and that they potentially could respond better to every 4-week dosing versus every 8-week dosing. So currently, guselkumab after the load, it's 100 milligrams sub-Q at week 0, week 4, and then every 8 weeks after that. So 8-week versus 4-week dosing, the question, I always kind of have this question in our patients who are a little bit more difficult to treat, is more drug better? So we'll talk a little bit about that. So other things to take in consideration in terms of how this study is relevant to practice, I think it's important to look at what response rates are seen in other studies that look at patients that have failed TNF inhibitors. So I'll try to pull that in as we go through some of the data. So this was a phase 3B randomized multi-center double-blind placebo-controlled studies. It enrolled patients with active psoriatic arthritis. So they had to have at least 3 tender and swollen joints. So 3 of each. So 3 tender, 3 swollen, an elevated C-reactive protein. And they had to have had an inadequate response to just one TNF inhibitor. So this is important too, because we all have those patients who have had, multiple biologic failures. And I think it's important that they kept those patients out of this trial, that they tried to make the patient population a little bit more homogeneous so that it was easier to see, whether there was a treatment response. So psoriatic arthritis, I generally will talk about this when I'm explaining to students or trainees about how psoriatic arthritis can be a little bit more difficult to study. Well, it can be more difficult to study than rheumatoid arthritis because there are so many domains affected in psoriatic arthritis. However, the primary endpoint in this study was to look at the ACR20 scores. So that's 20% improvement in joint disease. And then there was lots of secondary endpoints, including ACR 50s, 70s, the global assessment of psoriasis, the PASI scores, minimal disease activity, and they also included some patient-reported outcomes. The patients were randomized to receive either 100 milligrams of guselkumab every 4 weeks, or guselkumab in the dose that's approved, 100 milligrams at week 0, 4, and then 8 weeks. And then there was a placebo arm also. And then the placebo arm, once they hit the 24-week, they were switched into the every 4-week dosing group. So there was a total of 451 patients that were randomized to this trial. There were about 150-ish in each group. And in terms of primary endpoints, there was a statistically significant greater portion of patients that received guselkumab in both the Q4 and the Q8 week groups compared to placebo that met the ACR20 scores. So what that primary endpoint looked like, so in the 4-week dosing, they had a 58.6% of patients met an ACR of 20, and then in the Q8 dosing, there was 62.2% that met that primary endpoint versus only 34.8% in the placebo group. So I'm going to come back to this in a little bit in terms of the Q4 versus Q8 dosing. In terms of ACR 50 scores, there was a 31.4 or 32% in the Q4 versus Q8 versus 12% in the placebo group. ACR 70 scores, which are pretty hard to meet in patients with psoriatic arthritis. There was 17.5 or 17.3% of patients in the Q4 versus Q8 versus 2% in the placebo group. The PASI score, so PASI 90 was 49.4% in the Q4 week group and 45.5% in the Q8 week group, and then 12% in the placebo group. So another secondary endpoint that is pretty stringent marker to me is minimal disease activity. So this is a very hard measure to me, and for even some patients to meet it in these clinical trials is pretty impressive. So there was about 18.8% patients in the Q4 week dosing that met minimal disease activity, and 23.9% in the Q8 versus 5.4%. And all of these were statistically significant compared to placebo. The other things that we'll mention in terms of safety, so guselkumab is a really safe medication. The IL-23 class in general tends to be really safe. We have very limited adverse effects in terms of infections. This was consistent with all of that other safety data from the other clinical trials. If you're interested in a little bit more detail in terms of mechanism, so guselkumab is a little bit different from the other IL-23 medication on the market, risankizumab, and Danielle Gotti did a great job of talking about that structure and the mechanism in a podcast that was a few months ago, I think, or a few weeks ago. So I would check that out if you want more nitty-gritty in terms of the mechanism. But it is important to recognize that they are not the same and they are structurally a little bit different, but their mechanism is also a little bit different. So where guselkumab is binding to the IL-23 P19 subunit, it also has some activity at the CD64 receptor. So that is something that might make it a little bit different in terms of mechanism. And that's on the myeloid cell. So the way I like to think about it in terms of mechanism is that it is binding up the IL-23, which downstream has effects on different inflammatory cytokines like IL-17 and other inflammatory markers. But it also is stopping the production of IL-23 in the myeloid cell. So that's something that is, we're not just capturing up the pro-inflammatory cytokine or the signaling pathway downstream. We're kind of shutting it off at the start. So that can be really beneficial from an efficacy perspective. A few other things that I wanted to point out about this study is in terms of the patient characteristics. So there were a significant number of patients that were Caucasian, so that might be a limitation to this clinical trial. There was a good diversity in terms of, location across the country. There is an even distribution in terms of male and female. In terms of disease duration, so this is something I also always look at in terms of the patient characteristics. So all these patients had around 7 to 8 years of duration of disease. They were pretty matched well in terms of their swollen and tender joint counts, also in terms of their psoriasis and their patient's pain scale, like their assessment of pain was pretty similar across groups. So there weren't, other than the fact that they were mostly Caucasian patients, that they were matched pretty well. And those were that was kind of like the main limitation. The average age was about 50 years old across all three groups. So, how do I use this information, and how do I use this study to change my practice, or what does it give me in terms of treating my patients? So in some of our drugs that we use, sometimes using more frequent dosing can be beneficial. So for instance, in TNF alpha inhibitors, so like adalimumab, oftentimes we'll escalate to a Q week dosing for patients who are maybe just having this wearing off effect, whether it's related to anti-drug antibody development or just, the TNF alpha inhibitor bindings and saturating up all of that TNF alpha cytokine. We do see patients that do a little bit better on the Q week dosing. So, applying that concept to a drug like guselkumab, I was curious about this. So could our patients that are maybe a little bit more difficult, would they benefit from Q4 week dosing? So in this study, it really didn't show us that the Q4 week dosing was going to do a better job than the Q8 week dosing. So they were very comparable, and they were, and in some cases, like the primary endpoint, the Q8 week dosing did even better. So how do we explain that? So I think when you think about pharmacokinetics and dynamics, related to receptor saturation, so more drug is not always better. And if you're able to saturate up and bind up all that IL-23 and saturate the receptors on those myeloid cells, then if you can do that successfully with less dosing, then we have less drug exposure, less potential for the patient to have adverse effects, less issues with, doing injections. Well, every 4 weeks or every 8 weeks is really not very long or not very, frequent, but I think patients certainly would prefer to do every 8 weeks if they are able to see benefit and their disease is controlled. So in this study, in this initial data, really didn't show that the Q4 week dosing was better. So I think this is helpful to know that with our patients who have had exposure to TNF alpha inhibitors, we're still getting like pretty good responses in ACR20. While we can't compare across studies, so in other drug studies looking at psoriatic arthritis patients who've had inadequate response to TNF alpha inhibitors, so with risankizumab, with other classes of medications like our IL-17 inhibitors like secukinumab and ixekizumab, so across all of those studies, they're really the ACR20 scores range from about in like the high 40s, low 50s. So I don't know that there's any of those studies that they were able to get up into the 60s for an ACR 20. So that's something to consider. Again, these are different trials. They're not head to head. They're not, you can't compare them statistically to each other. But if we look at response rates, that sometimes is a little bit hopeful. So those are kind of my main points that I think to pull from this study. I think it's really helpful. Just another piece of evidence, a prospective study. There was some post hoc analysis, like I mentioned, and other studies that look at, whether the patients that have previous exposure, like how they do. This is very helpful to have a prospective study. If you want more information on guselkumab, IL-23 inhibitors, other journal clubs, please check out the WRAP podcast, our WRAPcast, or the content room on our website. We have a lot of content there. So there, like I mentioned, there's quite a bit on IL-23 inhibition. So if you want more details in terms of nitty-gritty, you can check that out. And thank you for listening.